Hello and welcome. I'm Hania Salah, the Director of Columbia University's Global Center in Amman. We're delighted to have you join us today for a vital conversation about the mental health effects and healing approaches faced in the aftermath of war. This webinar is co-sponsored by Columbia University's Social Intervention Group, the Committee on Forced Migration, and the Columbia Global Center Amman in partnership with the American University of Beirut's Global Engagement Initiative. It is the third in a series entitled After War, Learning from Past Conflicts. From the ethical dilemmas faced by journalists to the humanitarian and medical challenges, each discussion aims to offer insights on rebuilding societies torn apart by violence, highlighting the critical importance of learning from history to address present-day conflicts. Today's webinar spotlights the devastating consequences of war on mental health, the obstacles, and the possible post-conflict practical strategies, emphasizing collaborative efforts crucial for aiding recovery. This dialogue is essential as it addresses the urgent need to foster resilience and promote trauma healing among vulnerable populations. I would now like to extend a warm welcome to our distinguished panel of experts who will help to shed light on these issues. Ahmed Bawane is the country representative at International Medical Corps in Jordan. He has over 20 years of mental health and psychosocial program management and technical experience in working with refugees and other vulnerable populations. He has contributed to the field of mental health in the Middle East through research and program design, and is also the co-chair of the Mental Health and Psychosocial Support Working Group in Jordan. Ahmed has worked with different international organizations, along with UN agencies in the field of child protection and mental health and psychosocial support. Maya Bizri is an assistant professor of psychiatry and psychosomatic medicine at the American University of Beirut School of Medicine and an associate staff psychiatrist at the Center for Behavioral Health at the Cleveland Clinic. She is the founder of the Psycho-Oncology Program at AUB and a global mental health consultant for INGOs. She has conducted resiliency medical missions in the Ukraine and Gaziantep. Maya's global mental health efforts have been geared towards the mental health of healthcare workers and substance use in conflict and disaster settings. Lena Verdelli is Associate Professor of Clinical Psychology at Columbia University's Teachers College and the founder and director of the Teachers College Global Mental Health Lab. In the past 15 years, Lena has played a key role in landmark studies involving adaptation, training, and testing of psychotherapy protocols used by both specialists and non-specialists around the world. She has worked with academic institutions, health ministries, NGOs, and international agencies to alleviate the suffering in various groups, including war-affected adolescents in northern Uganda, Syrian refugees in Lebanon, and Rohingya refugees in Bangladesh. Lena is a Scientific Advisory Council member of the American Foundation for Suicide Prevention and the Scientific Advisory Board of the Depression Bipolar Support Alliance. She chaired the research work group of the Family NGO at the UN and is the first author of the manual on group interpersonal psychotherapy, which has been disseminated globally online by WHO. Moderating today's discussion is Anandita Dasgupta, a social and behavioral scientist in the Social Intervention Group at Columbia University School of Social Work. She also co-founded the multidisciplinary initiative ASPIRE, a program dedicated to leading meaningful research to respond to issues of forced migration. She is the principal investigator on an NIH-funded study to increase PrEP initiation and reduce intimate partner violence and hazardous alcohol use among women engaged in the criminal legal system in New York City. And Anandita is also involved with numerous projects focused on gendered inequities of health in Central Asia, India, the Middle East, and the United States. I now hand it over to you, Anandita.
Thank you so much. And thank you so much for this opportunity to moderate this important panel discussion today. I wanted to start by offering a few framing remarks for today's discussion. We are in a time right now where those, the panelists on this group, on this webinar, this panel, as well as all the attendees, we are all deeply aware of the issues, not just based on war, but also those who are impact those by of forced migration. with over 114 million officially displaced as of last year by UNHCR stats, we know that the issues of forced migration and war and displacement affect so many people across the globe. We often talk about issues that are the most headline catching, right? And we know we are in a time where we are constantly inundated by headlines from the news cycle. Those of us who are working in the humanitarian sector are thinking about countries all over the world where millions and millions and billions really are impacted by war. I wanted to highlight a few things. The concept of displacement, and I'll speak more broadly in terms of framing as displacement. War is that, right? It leads to displacement. Whether those who are forcibly displaced are displaced as a result of climate change related disasters or war, the result is the same. Incredible physical trauma and psychological trauma that comes from being isolated, separated from your home, from your loved ones, in addition to the physical and mental health impacts of the journey of displacement, in addition to the time and the causes of displacement, and then thinking about what happens after one has joined a host country and moved on. And so we often talk about the physical, and we often have to respond to the immediate primary needs, whether it's, physical burns, responding to physical burns, even for medication. We tend to talk about in the health sector about responding to the physical health needs. We spend less time talking about the mental health needs, though there's great understanding of the need to address these issues. And everything, when we talk about war, everything that people face as a result of war, not only has the physical impact on your body, but a mental impact as well. Whether it's PTSD, depression, anxiety, in addition to the many other onslaught of disorders. We've seen a rise in rates of suicidal ideation, attempts, and these are all we're talking about mental illnesses that may arise as a result of war. This isn't even beginning to unpack those many, many people globally, affected by war or not, who have underlying mental health needs. How do we address their needs in an ongoing basis? These needs tend to get put to the wayside when humanitarian actors are responding to war. This webinar today gives us an opportunity to really think about positive aspects of moving forward, really thinking about ways to respond to trauma as a result of war, and thinking about ways that, whether it's humanitarian actors who are working in direct services, whether it's policymakers, whether it's academics like myself, there's a role that we can each play. And the goal of today's webinar is really to think forward about what has worked, what has not worked, thinking about different approaches, whether it's immediate response or thinking with an eye towards sustainability. This is the focus of today's conversation. And so I really thank the organizers for bringing us all together to have the opportunity to really think about the future and thinking about what can happen. And I'll just end by saying, unfortunately, we have been seeing rates of forced migration, the number of people who have been displaced, increasing at a steady rate for the last 10 years. And unfortunately, given what we are seeing from everywhere from the Sudan to Bangladesh to the Congo to what's happening in Gaza, the numbers of people who are impacted by war are not going down. So it's time for us to really think about what we can do in terms of moving forward for innovative evidence-based approaches for healing from psychological trauma. So that's the landscape very briefly. And so I prepared a few questions to pose to our incredible group of panelists. And we have no shortage, as you've heard, in terms of expertise to really tackle this incredible task at hand. So I'll start with this question very broadly, I hope. So when we think about supporting the mental health of those impacted by war, what is the most pressing concern that comes to mind? And this can be, I've designed this as a very general question so that the panelists can really think about their own experiences and expertise. So Dr. Verdelli, we'll start with you, if you don't mind.
Thank you so much, Anandita. I'm going to share with you a PowerPoint that I prepared, and I hope this will also, is a broader frame also for our colleagues to add their own input from their own experience. My lab has worked around the world, and we have experience with both internally displaced persons and refugee populations, and at different points of their, after conflict, trajectory. Some of them have been for many, many years, 10 years after, the conflict ended and they left the homeland, others only very recently. This is such a timely, topic, because unfortunately, we have right now the highest number of violent conflicts since World War II, and there are 2 billion people, 1/4 of humanity, live in places affected by conflict, according to the Deputy Secretary General. And 18% of those in need of humanitarian aid receive it, less than 1 in 5. So there is tremendous need. I left, this is, the number of people around the world have been displaced, and I left it on purpose, unupdated, because this was done just some months ago, and it was 108 million, and now we are 117 million. And the projections are to reach 130 million, like 1 or 2 years from now. That's very high. So the war, affects people. It robs them of, it attacks the basic needs of human beings, right? For physiological equilibrium, to be able to recover, right? When there is too much stimulation and when there is stress, of safety, of nutrition and sleep. Basic need for education and work. Adults work, kids go to school. It takes this away. Basic need for having a family life and participate in the community. So there are cascades of losses that happen as a result of war. Losses of loved ones, injuries, amputations, right? Losses of animals that, are part of our livelihood or our family lives. Material goods like house and land, but also personal identities and social roles, how the person defines himself or herself, and the roles they play in the community. That goes away. The networks in the community that sustain the person, and rituals and structures, cultural and religious rituals and structures. So there are cascades of these losses. Now, in addition to the effects of war, sometimes we forget that people, everybody, all of us have pre-existing conditions, right? So in addition to the mental health effects, people also have pre-existing conditions. So this is something we need to keep in mind. Sometimes we think that everything started because of, what happened around the war, but people, as a result of the war, lose contact with either therapeutic teams or community supports that help them through this. There are, we need to think about cognitive and emotional vulnerabilities of, people that put them at higher risk, like people who tend to ruminate, for example, who don't have good regulatory skills. They have poor attachments and social support that increases the risk, in addition to, the extent and very important, point that I think the humanitarian world is becoming increasingly aware. In addition to paying attention to what happened during the war, it's incredibly important to pay attention to the recovery environment in the refugee camps, in the urban pockets, in the integration with the community. And I have some, I'll show you some evidence for this, actually. And for children. Children make sense of what happens to them based on the reactions of the caregivers, the grown-ups around them. So the mental health of the caregivers is critical for the trajectory of their responses. So human beings, have distress reactions to crisis, right? And they are normative. I don't even use the word normal, but normative reaction to extreme stress. And these are normative. Now, we get more worried as professionals when we see the person very withdrawn, disoriented, cut off and not speaking, unreal and confused, and unable to function, to care for self or others. The other thing I wanted to point out is that it's very important to consider at what point the trajectory we are talking about, the needs of the people, right? Those who have done trajectory work, over time after very traumatic events, have found out that in fact there was resilience, right, was the norm. So many people get affected, but usually the majority manage to find ways to adapt, not immediately, not from day one, but after some months, they manage to find ways to adapt. And then those who have chronic problems even before still remain, very symptomatic. The delayed response is not the norm, right? People who look initially well, but then they present the problems later on. But we have that trajectory as well, and then the slower recovery trajectory. So between resilience and recovery, we need to keep in mind that not everybody is going to be affected with mental health conditions. And this is important. Now, there is a level of stress that we call toxic stress, when people are so, overwhelmed, they don't have any respite for their, body and mind to recover. They are exhausted physically and emotionally. And this, of course, has worse, predicts worse trajectory. So this is a WHO, Fiona Carlson did the systematic review and meta-analysis. And the team found that, in fact, those who have, the mean point prevalence, not, at any different point, this is not lifetime, this point prevalence is 22% of people have a mental health condition. 22% of those affected in conflict settings. So 1 in 5. That's quite high if you think this is at least double of mental health condition of those who are not affected. And if you think about any exposure to any pathogen, if 1 in 5 people are affected and are impaired by that, that's quite alarming. But it doesn't take into account, by the way, those who have been under, this is an average, right? Those who have been under tremendous and toxic stress, and we see higher, higher levels of PTSD and depression and anxiety, and more difficulty in recovering. Now,
Dr. Verdelli, sorry, just one moment. I just wanted to catch on time
Yeah.
Can we move on in about 1 minute? I just want to make sure we get
Yes,
through all
thank you
the
so much. Yeah,
questions.
I was
No,
about
it's
to. This is what I wanted to point out first. That's why we need to pay attention to the recovery environment here and now. So it's this is with Rohingya refugees who had, experienced the genocide, but the direct, the daily environmental stressors in the camps mediated the relationship between trauma exposure and PTSD. And for depression, it really explained the relationship. So we need to be very careful, and pay a lot of attention to this. We have the interagency standing committee recommendations that all of us are very aware of. Not everybody needs specialized services. In fact, we have very good experience with helping, and training refugees to do this work with refugees, either refugee clinicians in Peru or for those who are less symptomatic, refugee community members supporting other refugees. So don't assume that everybody is traumatized, focus on current social stressors, and have a multi system, right, approach to this. Thank you so much.
wonderful. Thank you, Dr. Vidalia. And we have a lot of questions left to continue drawing on your expertise from. So thank you. Dr. Bawane, if you could comment a little bit on what you feel is the most pressing concern that comes to mind when we're thinking about the sort of psychological impact, mental health impact of war, that'd be great.
Sure. Thank you so much again for this opportunity. I think it's hard to summarize all what come to your mind whenever you experience an emergency and you try and look into what are the most pressing and concerning issues. I think I can go with a few of my observation from the Middle East emergencies, and one of those that maybe Dr. Lena just touched on those a little bit, which is we jump always during those emergency to label people with a kind of a trauma. It's true that there are a lot of traumatic incidents, but I don't believe that labeling people with people are traumatized or they have PTSD. I think it's one of the most common terms that even people from outside the mental health sector that they are aware of is the PTSD. I think everyone knows about the PTSD for some reason. It's not fair that we label people with the PTSD, and in the same time we forget that the resiliency level of the people that it's impressing. I would like to use one of the examples that I saw of the Syrian refugees when they came to Jordan, and I saw how people, they were trying to help each other, they were trying to support each other, they were more eager to try and look into the new opportunities on how to continue their life in new country, in a refugee camp where they don't have the families. I think it's not fair that we forget about this resiliency, and we try and, as much as possible, we try and focus on the traumatic the trauma and the PTSD, as Dr. Lena just mentioned. The second thing is I see that it's always impressive that the level of efforts to try and support financially is incredible. I think we are trying to compensate the lack of the human resources with the financial resources. And this is a kind of a normal response by the donors, right? When people, they try and look into, well, how there is an emergency in such country, what can we do? Let's pump a lot of money there, which is great, but how we use those money. The third observation that I have is trying to focus on mental health and forget about the psychosocial level. The pyramid that Dr. Lena just showed us, the people who are in need for the specialized mental health services, they are this small percentage on the top of that pyramid. But the majority of the people who are in need for the psychosocial support are on the second, third, and the fourth level of the pyramid. One more point is, I learned in Libya, in Jordan, in Syria, in Iraq, that the more we invest in the low level in that pyramid, in consideration of the psychosocial aspects, the more that we save and the more we prevent people of developing mental health disorders. I don't believe that all of the people who are affected by the traumatic incident would develop mental health disorders if we provide them with the proper psychosocial support. And that vary from the general level of consideration. For example, when we are trying to provide the people with the non-food items, how we can train the people how to provide them with the non-food items with a kind of dignity to the going up to the psychological support, the general support, creating the space for the people to talk and to engage with the social activities, give them opportunity to try and support their families rather than trying to diagnose people with disorders. I think overall, my last observation that emergencies always they come and they bring opportunities. Don't hate me for this statement, but I think let's take an example from the region where I am sitting. Let's say Egypt. We don't have any emergency now, right? If we say that we need for some financial support for the mental health, I don't think a lot of people will be interested in supporting the mental health system there. But when we have an emergency, there will be a lot of opportunities that they come for this. So I think the best and the smart way is to try and focus as much as possible to build our emergency response in a way that can shift easily to more of a developmental approach where I can speak more about it, but I don't want to stretch you in detail with the time. So maybe we can speak later on how we can use the opportunity of the emergency to for of developmental approach for the mental health programs in the area of conflict or war. Thank you.
That was fantastic. There's so many points to consider, and I want to give Dr. Bizri a chance to respond to the question, and then I think there's plenty of room for discussion. So that's fantastic. Thank you. Dr. Bizri. Oh, you're on mute.
You're on mute.
Thank you for inviting me. It's hard to answer after seasoned colleagues. I'm a bit in this, but I'll speak from my experience. I started working by default in global mental health and in disaster settings. And I think one thing I've noticed is when we talk about and mind you, I come from I'm a clinician, so I come from a very clinical background. And so obviously when there's a disaster, when there's a war, there's this urge to deploy immediately and just intervene with what you know, whatever skills you have. And I think one, it's a poor allocation of resources, and I'll talk about this. And two, I just wanted to speak to what is, to answer your question, when you say what is the most pressing, so the most urgent need when there's an actual war, I think, I mean, it goes against everything you've learned in medical school, but really the most pressing needs are non-mental health needs. The most pressing needs are really, I mean, social determinants, if you want to call them anything in public health, but safety concerns, housing, shelter, nutrition. We see a lot of hunger and famine in these cases. And I think that falls in some way, why that is more pressing, because I mean, whatever you want to call it, whatever type of trauma you want to call it, now people are going into dividing trauma terms and concepts and types of traumas. And I get that. But whatever the trauma is, inherently, the basic concept is that the person experienced compromise in their sense of safety or security. And so you really want to make sure that you give them that from the start, so you can prevent any PTSD or any traumatic reaction later on. And as Dr. Verdelli and both Mr. Bawani had mentioned, that so the norm is resilience. Most mental health illnesses will actually come up at the 1-year anniversary and later on. So most PTSD or any other trauma reaction will only any pathological trauma or impairing trauma will really exhibit itself a year after the event. And that's when you should deploy. And that's when you should allocate your resources. Unfortunately, Ahmed had mentioned that you get a lot of financial resources at the start when there's the initial trauma, but you really don't get them later on. So I think part of the allocation of resources has to take into account that the mental health interventions comes only later on, so a year onwards, and that's when you should save your money, your finances for what you should save your finances for. I don't think we all have that mindset. I think we all aim to create something sustainable, and then we get shortages of funding, and a year into it, the program is no longer sustainable, whereas this is when the population needs it the most. So I think this is a discrepancy that needs to be addressed. I think another thing, which is a topic I've personally noticed and I'm interested in, is redefining really who is vulnerable. I think we tend to focus on obviously refugees, displaced because of the war. We tend to focus on children, obviously, and because early intervention is really preventative. We tend to focus somewhat on women and pregnant and elderly, but a lot of the other vulnerable populations include, well, the elderly for one, those that have, as Dr. Verdelli had mentioned, previously severe mental illnesses, because inherently these already have, people that have severe mental illness do not function as well in society as other people too. And so social determinants of health are already marginalizing those. And so these are at higher risk, and you don't see a lot of focus on this in mental health interventions. And the last population I'll mention, which is something I'm very passionate about, is that of healthcare workers. I don't think they don't get nearly the attention, anything close to the attention that they deserve in terms of being a vulnerable. So we tend to look at them as a resource instead of a population at risk. And I think our mindset, if you want to get any early intervention, you should really focus on intervening among healthcare providers, not only preventing different types of trauma, whether that's moral injury, burnout, secondary PTSD, or really equipping them with skills to deal with patients who have trauma later on. So if you want to intervene early on, I think that's the population you should start with. I hope that answered your question.
Perfectly. Thank you. This is great. And it's helpful to hear some of the overlap between your perspectives. You all come from a similar sector, but different approaches and backgrounds. So it's interesting to hear sort of the commonalities across all. My next question is you've all touched on this a little bit, but I wanted to give a chance for you all to elaborate a little bit more in about 2 to 3 minutes. Can you talk a little bit about gaps to existing mental health programming? So we've talked about what doesn't exist and all of that, but for those programs that do exist, or infrastructures that do exist in response to humanitarian crises after war, what gaps exist? And you can talk about programming for direct services, policy, you can talk about research, but what gaps exist? So Dr. Verdelli, do you want to start? You're on mute.
Yeah, thank you. A number of things come to mind. One that I'm personally and my team is very interested in, and we have started now doing some research, is in terms of research gaps that you mentioned, Anadita, is I want to understand, from the local point of view, what the persons affected by war, our refugees, our displaced persons say, and their own perceptions of what constitutes like optimal adjustment to this at different stages, of the journey after the war, right? During and after the war, when all the social roles are compromised. They cannot work, they cannot take care of the kids the way they used to, they cannot participate in the community. What do they define? How do they understand? Good optimal adjustment. This is something that, instead of us thinking that's how people should work. We need to really focus on that and capture that and be guided by what the local folks who have experience, people with lived experience, say. So that's one thing that comes to mind. And the other is to underscore two things that colleagues have said. Ahmad said, something, many things, but what has been also my experience in terms of the policy. It's such a great opportunity to build, infrastructure, mental health infrastructure that serves not just the displaced refugee population, but also the host population. So you reduce the resentment that people have, towards refugees that come to the country, et cetera, et cetera. And many times the narrative gets exploited, right? So in Lebanon, for example, my team was able, despite all the challenges in Lebanon, to have a very sustained mental health program, because there are policies in response to Syrian crisis that serve everybody there.
Thank you. That's very, very helpful. Dr. Boane, do you want to comment a little bit?
Sure. In terms of gaps, I think it's again, it's good to look into the gaps from the perspective of how to leave the emergency with great sustainable programs there. So it's two things: looking into the gaps and also to consider how the sustainability of our programs are. And one more time, whenever the emergency starts, everyone is trying to invest in the money there. But it's true that if you want to draw the curve of the needs, it starts from minimum level, and by years it increase, and maybe in 10 years the needs will continue to be increasing. But the financial support will start on the top level after the emergency immediately. Think about the earthquake in Turkey that happened and how much money they were invested there, and now how much investment in the mental health now is happening. So it goes down opposite to what is supposed to happen. So we need to think of how smart need to be in investment in the mental health. And the first thing that I see that we have a lot of investment in the mental health treatment, but again, those are not the immediate needs at this stage. We need more of the psychosocial support. The gap that I believe that we always facing, especially in the beginning of the emergency, is the information about the community that we are trying to serve. How much are those needs? And again, it's not only just to conduct a survey and we say, well, 70% of the population, they expressed depression symptoms, signs, or they expressed about how they are anxious about their future. It's more about how those information can help in building our programs. I see a lot of investment in capacity building, which is great, but we need to rely also on evidence-based interventions when we are trying to build the capacity of those people that we are considering for the future. I mentioned in the first question, Anindita, that we always face that increase of the financial support, but also decrease in the human resources. Think about any of the emergencies. Always we find that number of psychiatrists are decreasing, because those are the ones that either they are few, but also after the emergency, the pressure on those are increasing, and some of those are leaving. The psychologist is the same. So we need to look into how we invest in evidence-based interventions. And here I'm a big fan of the low intense interventions, that they are evidence-based interventions by WHO and other institutions, where you can rely on train social workers or on providing support sessions, or teachers or nurses to help in supporting the psychiatrist, train the general practitioners like a match gap program, train the general practitioners and the family medicine doctors to be able to diagnose and also to treat mental health interventions. I saw this happening, and I would like to shed some light on Gaza response, where we try to respond into Gaza, and the interest there is to try and bring as much as possible of surgeons as gynecologists, but all of the emergencies, we're trying to prioritize the people who can operate in the operational theater, where psychiatrists and psychologists, they were not prioritized. What was helping, that we sent those doctors who are trained on MH gap. We sent people who are nurses who are trained on PM plus, for example, and all of these interventions. Those are the ones that they managed to triage and also treat sometimes some of the mental health problems and support the system. So this is kind of where I feel that can be a good investment and can be a kind of long-term investment. One more thing that maybe we can look into the gaps and how to fill is the information sharing, and where setting a coordination mechanism and or a platform like the working groups or the technical working groups that as part of the humanitarian response and the humanitarian coordination is something important, because that would avoid a lot of duplication of the services, would share a lot of information in terms of research assessments, and this would be helping in filling a gap of lack of information, as every emergency always start with lack of information about the reality of the needs. Thank you.
Amazing. And thank you for those concrete examples. I think those are very, very useful. Absolutely. Dr. Bizri, would you like to comment a bit on what you see as gaps?
I don't want to be redundant, but I'll mention something, I think an example that speaks to what Dr. Verdelli was saying. She mentioned the needs of the host community and really avoiding resentment that might develop. And I want to speak to that because well, first, I think one of the gaps is really our understanding of the needs, as Mr. Bawani had said, which is going in with some sense of cultural humility. I think for example, I very naively went to Ukraine trying to, pilot a model where we were trained other healthcare workers, and very briefly, in skills for psychological recovery and in how to deal in trauma-informed care. And the group that we had piloted was, a combination of nurses, doctors, physicians that had volunteered to attend the sessions and to be trained. And I had not been very aware of the political differences within Ukraine between people that had been displaced from the East and the host communities in the West. And these came up really when people were giving examples of patients from the East they were forced to treat despite being politically not really very aligned with, in the middle of a war where everyone is compromised and everyone's family is compromised. And so I think getting a sense of cultural, going in a bit with some humility and cultural sensitivity to the realities that the population you're addressing faces, and to avoid any resentment, we really have to focus on what the host community as well is experiencing as secondary trauma. I think one point that was mentioned was policy, and it's true that policy is important, but policy really needs a lot of data. And so I don't think we should minimize, I disagree with Mr. Bawani, I don't think we should minimize the importance of surveys and epidemiological data. And just to give you an example, so the first work in public health, it was not a war, that I had been part of was really just an epidemiological survey in Lebanon about the rates of suicide. And that was the data that allowed us to fund for the National Suicide Hotline. And so I don't think, I know we all want to do interventional work that is much more complex, but I think that data matters a lot, and monitoring data matters a lot in terms of really pushing for a policy. So that's a gap. I think we all tend to focus on really interventions, but I think even basic surveys are extremely important and really they're undervalued. What else did I want to say? I wanted to say, I wanted to mention, it's something that I mentioned a lot, funding gaps. I think if you look at the latest research for allocation of resources in terms of mental health research funding, we do talk about how mental health is much less funded than physical health that is present everywhere. We do talk about how after a war, just as Mr. Bawani was mentioning, there's like this sense of urgency that comes with funding at the onset, but that kind of dwindles as the war progresses and the conflict progresses. But also if there's a discrepancy between, and I think this is why you get communities that are not very engaged in the research, it's because there's a discrepancy between, so there is over 5 years, I'll share the report if you want, $18 billion were allocated to mental health resources. 97% of those came from high-income countries, but again, 98% of those main researchers were also in high-income countries. And so that kind of just perpetuates a discrepancy. So that what that translates into is that most low-income countries or war settings or low-resource settings will end up having passive data collectors that are not really engaged in the research and that will not really tell you the needs of the community. I think, so in terms of allocation of resources, just looking at low middle income country researchers as a bit more of innovative researchers that can have control over the data, that can have data ownership, not just collection, but also that can dictate what the research agenda is. I hope that makes sense.
It absolutely does. Thank you. We just have a few more moments before I want to switch us over to responding to some of the questions that were posed. But I wanted to open it up quickly to the panelists to respond to each other. If there's anything that you want to kind of highlight to each other, respond to each other. Dr. Bawani, I don't know if you have anything that you might want to add in response to Dr. Bizri's comments too in particular.
Sure. Not to respond to the questions, but it's more of related to the examples of what we can better invest. I'll give you an example from Jordan. As you know, Jordan is a very stable country, but we have a lot of refugees where we found that both host population and the refugees, they are having almost the same challenge, which is the stigma. We don't want to go to the clinic because we don't want to be seen as, oh, those are the majnoon, the crazy people who are coming to the clinic. The second challenge, especially in the south of Jordan, where the transportation cost is very high. So does it worth to go to the clinic and pay around $15 in some of the governorates to get the treatment, the mental health treatment. Again, Jordan is very stable, so we don't have any challenges with the electricity or the internet. So we came up with that kind of an application where we thought that it's a good example for shifting from the humanitarian with using the fund that we were getting for the humanitarian needs to come up with a more of a developmental program where we managed to introduce the application called Relax, even in Arabic, that if you are in Jordan, you can download it and then it's for free. Then you can talk to the people who are assigned in our clinics there in different places. So it takes sometimes 1 or 2 sessions for those patients to break the kind of I don't want to call it a stigma, because sometimes that people, they are hesitant to go to seek the services. So that's one side. The other side, that we find that training, you remember I mentioned training the family medicine doctors and the GPs, take them away from their clinics for 5 days to receive a training in a hotel or in a place that it's not affordable for them. So we thought of shifting the MHGAP program, which is the training for them on how to diagnose their mental health conditions, into a kind of a more of videos and kind of interaction platform that we put it also in the same application where they can enter and then they can get a training. That's an example of what I wanted to share with the group on how to utilize as much as possible of the emergency fund for both purposes, for the host population and also the refugees themselves. Over.
Thank you. Thank you so much for that example too. That's very exciting. Dr. Vidali, I saw you came off mute. Would you like to add anything before we jump to
Yes,
questions?
actually, it's also in response to a question, and I realized that, you know, I don't want to misspeak here and give the message that people will be fine, you know, nothing's happened. That's not what we are saying. We're, you know, in fact, those who get affected, like, you know, 1 in 5, and if there is toxic stress, more than that, are sometimes, you know, it takes a very long time to heal. Sometimes with time, they stay the same, become worse. So the question here from our colleague there was, how do you know, the kids in this case, South Lebanon, who are constantly bombarded, you know, by sounds and messages and the witnessing, how do you help these kids who seemed incredibly anxious, right? So again, it's really very important when people are in this state. It's very hard for the body and mind to protect us. It's very hard to tell what is safe from what is not safe. It's so try to help the kid, especially in a group setting, so that you create a new community, you know, of people to start getting, you know, connected to each other. You know, they can talk about it. What could be safer? What is not safe? How do I know it? Ways to down-regulate their body. Breathing is cheap. In fact, it doesn't cost anything, you know, ways to unhook your ruminations so that it can be more, you know, helpful. How do you let grown-ups know that you need, you know, help? Right? Who can help you? Other peers, and try to restore as much as possible routines, daily routines. And there are many interventions, both of my colleagues mentioned, that are not therapy, but are very therapeutic. Art, soccer, there's this organization we're working, grassroots soccer, you know, but structured time, give joy, and can be very therapeutic. For those who need much more, we need to pay attention to those who, you know, may be silent, don't say anything, don't create a lot of, you know, don't attract attention, but are suffering tremendously. So here is where, you know, as we said before, there are some free of charge WHO, you know, UNHCR disseminated instruments, either for self-help plus, and then therapies for those who need more, right? PM plus, IPT, and in the private domain, now there's like CETA, which is very effective as well. So the question is, you know, how, for those who need more, how do we give as much or as little help as they need? So have a stepped care program where people get, you know, different levels of help, and we triage it according to the how people respond to these. For that, though, we need coordination, and as both Maya and Ahmad said, in the beginning, we have a lot of resources, but not a lot of coordination. And that's something that is missing. Thank you. Maya.
Yeah, go ahead, Dr. Bizri, go ahead.
I'm just going to be very quick. I think I wanted to mention something that was brought up a lot. We talked a lot about, you know, providing long-term solutions. And I think as a researcher, if you're a researcher into the mental health, global mental health space, or if you're a clinician, you want to provide care that is both sustainable and scalable. This is what we've all been taught going in. But I think, as we've mentioned this before, I don't think that's always feasible. And I think sometimes you have to make difficult choices that is restricted by funding, but that is restricted also by the reality of the place. And I think personally, I don't know if my colleagues agree, I think sometimes you just have to pick sustainable over scalable and go with that. That's not always what you're looking to do, because if you know that an intervention works, you want to replicate it elsewhere. But I think it's better to focus on not replicating it and sustaining it for a longer period of time if you need to make that choice. I hope that is clear. And I wanted, just from a clinical point of view, to also mention something. I know we talked about different types of traumas, whether that's moral injury, where you have to make difficult choices. It's not just PTSD, right? It can be burnout, it can be secondary PTSD, but there's also, most of these populations have also a background of intergenerational trauma. They have inherited trauma from their parents, from their families. And so family-based interventions are really helpful. Just as much as community-based interventions are helpful. I think understanding the trauma that the family has faced, whether it's a displaced or host family, is extremely important in treating or in healing that trauma.
Thank you so much. And I know we are very short on time, but I want to just present one more question from the Q&A. Thank you all to the attendees for your great questions. So just in general, not everybody has to respond. You can, if anybody has, any of the panelists has thoughts, please jump in. So there's a question: what are your thoughts on the issue of prolonged war conflicts where people affected by the war remain uncertain about its end for years? How can they be helped during this seemingly endless uncertainty? So, open it up.
Yeah, it's, and their needs change in different stages, but like with every chronic situation, there is demoralization, that is associated with that. It needs to be acknowledged. So it's very important to assist the person. First of all, create community, because as Maya and Ahmad said, it's the community support is very healing, and help people, try to maintain some sense of agency, try to differentiate what they cannot control, but what they can control, and try to mobilize, structures and people. Sometimes people have more power than they have, in refugee camps, sometimes, block leaders, in Rohingya refugees. So who has more power? NGOs, representatives from, WHO, UNHCR, who has more power than them that they can, engage to get help? This is something that, because it's really important to maintain a future orientation, and ways for the person to not give up, go into a state of hopelessness and helplessness.
I think in ongoing trauma, I'll just be very brief, in ongoing trauma versus acute trauma, where people at the onset of the trauma just we all know psychological first aid. This is what most people deploy and do there, which is very important. But I think in subacute trauma that is compounded by chronic conflict, I think one of the more evidence-based trauma interventions, which is not clinical, but it's skills for psychological recovery. And what I like about it's flexible, it's culturally sensitive, it covers all age groups, and I'll go into what that means. And it is targeted towards promoting recovery versus addressing trauma. And I hope that the difference is clear, in the sense the outcome is really on equipping people with skills that will put them in that group that becomes resilient if they need to. And the basic skills that they teach you, and they can be taught by non-mental health providers, which is why it's such an amazing intervention, is anyone who learns it can teach it. It's very standardized. It's translated in different languages. And the skills that are taught are emotional flexibility, how to manage distressing emotions, how to promote positive thinking, how to problem solve things, and how to prioritize your own needs. Because sometimes when patients are overwhelmed with trauma, they can't really figure that out. And so I think a lot of interventions are good, but I think it's one of the interventions that is more evidence-based, as Ahmed was stressing. I like it personally.
Dr. Bawani, do you want to add anything?
Well, I think both colleagues, they covered it very well, but I think there's what you can control, what you can't control. What you can control is to try and advocate as much as possible, because we don't want to forget that also we are not only MHPSS actors, but also we are humanitarian actors, and we advocate as much as possible with donors, with government, with policy making, and all of that. And this is something that we are committed to. And also we try to respond to the needs, and this is where, as my colleague, both Maya and Dr. Lena, both doctors, they mentioned the need of the understanding of the situation. And this is something that maybe we don't want to do an assessment at the beginning of the emergency and then that's it, we know everything. I think in a couple of months, maybe if in a couple of weeks, maybe you will have a different situation where you need to shift a little bit from implementing something to something else. I know that in some humanitarian contexts that lasted for years, now is the shift toward a kind of a long-term treatment, and also in the same time covering and supporting the supporters, the humanitarian actors as well. Over.
Wonderful, thank you all. And I think we will go a little bit over, but we have such great questions, and so the organizers have given us a little bit more time. So I'll just ask one more question. And Dr. Bawane gave an example of what's going on, one approach that they used in Gaza, and so I thought I would end with one last question. So there's a question where someone is talking about that they have a team in the Gaza Strip. They're working with them pretty regularly. They bring up a really great point about issues that are hidden at homes and with other relatives, and not so much in tents or in the UNRWA areas, where there might be professional psychosocial professionals who are able to see the issues. Any thoughts about addressing, whether it's in Gaza or honestly in any humanitarian crisis, how to address mental health concerns for those who may be at home, who might be falling through the cracks in terms of where folks are going for receiving services, not in a clinic or a tent necessarily?
I can start, and then I will open it for Dr. Lena, Dr. Maya. One of the useful components that we believe that always is needed is the community support and community awareness around the mental health issues. And this is something that we found it that you don't know how much of messages that you send to the people, that they reach to the people that you are still missing, and they are not appearing to you. And that's something that we keep sending messages through the different other actors, and this is where our role as MHPSS actors, in coordination with the other actors, for example, the health, the education, the shelter, all of those people that we consider those maybe they be exposed to more of those cases and more of those people who are in need for the mental health, but they are not seeking those support, or we are not reaching to them. And those are the main referral hub for you, because those are the ones that they are sending the messages to the people, especially if they trust the service, if they trust you, then they speak on behalf of you, and those are the best in identifying and also referring those to you. The second part is more related to those people who we don't deal with, especially the children, that we don't deal with children directly, but we deal with parents, and there are certain programs that they are addressed to the people who are looking into the children, and also the people with some disabilities, physical disabilities, where there are also evidence-based and low-intensity programs that we tested, and we know that they are helpful and working. That's from my side. I'm sure that the colleagues they have different also aspects. Over.
Yeah, if I understood well, Alia's question was on the team that they have, like the humanitarian work, from what I understand, who are quietly suffering, and they are not, and how to address their skills, especially if they're not professionals around. This is my understanding of the question. And it goes to what all of us have said, Maya, especially about the need for those in the front lines. So there are a series, again, we go back to the step care program. Sometimes people can recover enough to function better with some clarification, support, and down regulation. And there are tools for that, free of charge, can be downloaded, like Self-Help Plus, translated in many languages, to help people, do some things on their own to try to, work, function better, and calm their mind, find some respite and peace. The other thing is, with digital, there are some tools now, digital tools, to help, a number of or networks. And I get this more and more. We have this new initiative in Ukraine, and I've been approached with how, for example, people in bicycles, people with community health workers, essentially go from one place to another. We provide minimal training, this 3-session, intervention, IPT based, but very simple, to give structured language to ask people, tell me what's happening in your life, and very specific tools for them to answer. And then it's also very, very important to get people in touch, with online resources. There are networks, and we can perhaps provide, some networks and resources so that our colleagues who need them to be able to get in touch and link people to services.
Dr. Bizri, anything to add?
I'll answer this with the question that I think I saw a question addressed to me, and I think I'll lump them in the same answer. This is something that it's very close to home. Healthcare workers and that includes humanitarian workers, and the different types of trauma they go through and how they fall through the cracks. But I think one of the interventions that I was discussing is really, and this is not sponsored, but it's really a very effective tool. It's manualized, so you have a manual that goes through it. It's translated in different languages, and you don't need to be a trained clinician to actually do it. So the way everyone does psychological first aid, I think in the coming few years, you'll see everyone doing skills for psychological recovery. This is evidence informed. It is not a clinical intervention, so this is not CBT, but it is a manualized tool that teaches you skills that will promote recovery. This is what I mean. So these are building problem-solving skills, promoting positive activities, managing intense reactions, whether that's anger, frustration, irritability, promoting helpful thinking, and rebuilding healthy social connections. And I think people are just more comfortable with skills for psychological recovery, and they are effective, but they are effective in the first onset of crisis, in stabilization. Once you have a stabilized population with the new norm, this is when you implement skills for psychological recovery. It's called SPR, and it's present everywhere. If you need it, I can send it over to you as well. It's translated into different languages. It's validated into different populations, and I've seen it work. So I hope that answers everybody's question.
Thank you, and thank you for grabbing that question from the chat as well. So we've had a great discussion. I want to thank the panelists again, and I'll just summarize very briefly, very quickly, before handing it over to my colleague to close us out. So I just wanted to highlight a few key themes that I've heard a few times. So One, really thinking about also not just the mental health impacts that have been brought on by war, but also thinking about those who have had pre-existing conditions around mental health and supporting those. I really appreciated Dr. Bawane's point about the space and the difference between financial resources and humanitarian resources. I think this is something we also saw during COVID as well. So I think that's really important. And a number of the panelists also brought up the importance of thinking about what happens with that money, when the money comes in, and how it's used. And so I think as we're talking about different approaches and the future and sustainability, these components are really important. Dr. Bizri brought up a great point about redefining who is vulnerable and the need to focus on those, again, who have those pre-existing conditions as well. Dr. Verdelli's perspective around really making sure we're capturing the voices and needs straight from those who are most impacted, those with lived experience and living experiences is really, really vital. And finally, I think everybody really brought on, tagged to this one point around how do you leave an infrastructure? How do humanitarian actors leave existing infrastructures with an eye towards sustainability and better than it was before? In addition, I think there were some really incredible resources, taking notes furiously about the different types of treatment options and perspectives that could be applied, and some really practical solutions and suggestions as well. So thank you. And now I'll just hand it over to Tanya Haddad, who is the director of the Global Engagement Initiative and an associate professor of public administration and nonprofit management at AUB, to close us out. Thank you.
Thank you, Anandita. Thank you all for an incredibly insightful and dynamic discussion today. As concluding remarks, I want to take a moment to reflect on the key themes and lessons that have emerged from our conversation, and which I believe will be instrumental in guiding our efforts in post-conflict rehabilitation. First, the importance of addressing both immediate and long-term mental health needs cannot be overstated. Our discussions highlighted the necessity of balancing urgent humanitarian responses with sustainable developmental approach. Second, we've identified significant gaps in mental health programming and research that needs our attention. The insights shared on the need for more comprehensive trauma-informed care emphasize the importance of continuous support rather than isolated intervention. Third, our conversation underscored the critical role of innovative and context-specific approaches. The examples shared from Helen Verdelli's work on enhancing recovery environment to Ahmed Bawane's initiatives on transitioning from emergency to developmental phases, and Maya Bizri's focus on sustainable solutions for marginalized communities, all demonstrated that adaptable and locally informed strategies are keys to success. Thank you once again for our esteemed panelists for your valuable contribution, and to everyone here for your engagement and dedication to this crucial work. This discussion is part of a four-series discussion on post-war reconstruction, a collaboration between American University of Beirut's Global Engagement Initiative, Columbia Global Center Amman, the Social Intervention Group, and the Committee on Forced Migration. Make sure you follow our channels to learn more about our fall events. Have a great afternoon.